experience where I have had moms that simply have not made it to the hospital. And if it wasn't for your quick actions, your calmness for those parents and that, don't know what they would have ever done without you. I am an old OB nurse. Actually, I graduated back in 1977. By 1980, I was working in a 17-bed rural hospital, nights, doing deliveries, worked up in northern Minnesota, came back here to Avera St. Luke's in 1981, worked labor and delivery up to 3 years ago. I have taught obstetrics and pediatrics both for PC or presentation as well as SCFU. So I've had a lot of experience that way. And like Kyle said, that, well, this is one of my last hurrahs before I get to sit back and relax. And the thing is, I have done a lot of deliveries where the doctor hasn't made it. The thing is, I've been fortunate enough that my deliveries have been in a more controlled environment where you may end up getting a call. They're on the side of the road. And I know that that has happened. So it's the biggest thing I'll tell you right now is just that cool, calm, and collect. And even if you haven't done a delivery before, just, you know, they'll look at you and they'll say, do you know what you're doing? And you'll say, just stay calm and you'll get through everything. Kyle?
All right. Thanks a lot, Linda. Linda's going to be available for some questions and some input as well throughout the evening. So we plan on going for about an hour. I think tonight is kind of where we're going to land. And we're very happy to have Linda on board. She's been a nurse for 44 years, so a lot of experience there. And for those of you up here in the Aberdeen area, I'm sure that you know who Linda is. So we're going to get started. Is there any questions, I guess, before we get going? All right, so I'm going to stop my video. I'm going to share my screen, see if I remember how to do this so I can get the screen up that I want. Give me 1 second here. I'm working off of 3 screens tonight, which is a little more than I normally do. All right, Michaela, can you see just the PowerPoint?
It looks like you're not sharing a screen right now, Kyle.
Okay. What do we got going on here? How about now? What do you got?
I see the PowerPoint, all the slides on the side, and then the notes on the bottom.
Okay, I'm almost there. Now what do you got?
I still have that same screen. If you go to share at the bottom, you should be able to select which screen.
Did it change at all or no?
Nope.
tell you what I'm going to do here. Hold on 1 second. Make this easy. All right, Michaela, what do you got now?
Your slideshow, perfect.
Perfect. Okay. All right. So we are going to talk tonight about emergency delivery and newborn stabilization. And like I said, we're going to go for about an hour. I know we had some questions that came in over the registration process. So we'll get to those as well. So what we're going to do tonight is we're going to discuss the triage of our laboring patient. We're also going to talk about resuscitation. We're also going to describe the steps for performing a vaginal delivery. And we're also going to describe those steps in resuscitation of a newly born neonate as well. So here's our case presentation that we're going to be referring to tonight. You guys can all hear me okay? Right, Michaela, everything's good?
Yep. If you could be a little bit louder, that would be good, but for the most
Oh
part,
yeah, I
yes.
can be louder. Don't have to worry about that. Okay, so we are called to the scene of a 20-year-old woman in labor. ETA to the scene from our station is 5 minutes. Our ETA from the scene to the nearest hospital with delivery service is 12 minutes. We all know that in rural South Dakota, this is probably not going to be the case. We might have an ETA from the scene to the nearest hospital of 12 minutes if we're in the same community as our hospital, but maybe they don't have delivery service. But if we are under the gun and we have to go there, those hospitals will and are trained and are capable of delivering if need be. So we review en route our triage of our laboring patient, those steps that we need to do. We also maybe go to our protocols, and for those of you that are running off of South Dakota BLS guidelines, it's going to be on page 86 through 89 of the state BLS guidelines that are out there. We're also going to review our steps of resuscitation of the mother and the newly born infant if need be. Most of these types of deliveries are going to be very natural. There's not going to be a lot of stuff that we're going to need to do, but there are those certain number that we will have to do resuscitation of the newly born infant or potentially the mother. So we get this. This is what we see when we arrive on scene. I didn't warn you. Sorry. This right here is going to give us the question of what is our next step in the care of this patient. What do you guys think? You can unmute and tell me. What are we able to get to the hospital, or are we delivering this one? You guys can unmute and answer the question.
You're going to have to deliver that one.
Yeah, we're delivering this one. We are not going anywhere, are we? So we are delivering this one. What is our next step going to be? So some questions that we can ask our patient. Is this your first delivery? If our patient says, no, this is whatever number, how long was the labor of your first delivery, of your last delivery, those questions. Another question to ask is going to be on the gravida and the para side of things. When we say, is this your first delivery, it's also good to know how many times has this female been pregnant. That's the gravida scale. The para is how many times has our patient reached that viable gestation age, which is 24 weeks. So those are all questions that we need to ask as well that we may want to pass along to our medical control or the doc, whoever we're talking to, maybe on the phone or on the radio. So those are good numbers to have as well. And it doesn't matter on either side of it if of the viability of either one of those. Gravida is just number of times pregnant, and the para is the number of pregnancies reaching that viable gestation age of 24 weeks is where it's at right now. So another question that we're going to be asking is, do you feel that urge to push? If mom says yes, delivery is going to be within 30 to 60 minutes and probably even a little bit sooner, especially with what we saw in our picture. We are going to be delivering probably within the next few minutes. So we also need to, we definitely need to get that look of what's going on with mom and understand what's going on in that perineum area, do that assessment there, and understand if delivery is going to be imminent, if we have time to go, or if we need to prepare to deliver where we are. So when we're doing that assessment, look for crowning. Do we have visible appearance of that fetal head? Is it there? Is it there during the contractions? If it is, we know delivery is definitely imminent there. We probably should not move mom at all. We should do this in the house.
Right.
Hopefully we're in the house. Does somebody have something? Like we got somebody that's not muted. If we do see that child's head crowning during the contractions, we're going to be delivering. So we don't really want to move mom here. So another key concept when we're talking about deliveries is 4% of deliveries are breech. Inspection of that perineum shows, if it shows a foot or a buttock, that is not going to be something that we're going to be able to deliver in the field. We need to transport that patient to the ED, probably get some more help coming to us if it's not already, and get that patient to the ED as quick and as rapid as we possibly can, also as safely as we possibly can. So these breech deliveries do carry a much higher risk for both the infant and the mom than our normal type of deliveries. And given those risk of complications, a lot of times these are going to result in the cesarean section, the C-section, to deliver that baby. So what we found out is as our case is progressing, this is the woman's second baby. She states that the labor with her first baby was short, relatively short of 2 hours, and that she feels that urge to push. So once she's in that urge to push, she is getting towards the end of her labor. And in generally speaking, if that mother has that urge to push, that delivery is going to take place within an hour in first pregnancies, but within 30 minutes once we start getting into that second, third on up pregnancies. So now let's talk about resuscitation-oriented history. What are we dealing with here? Are we dealing with a multiple birth? When is that mom due? What color was the amniotic fluid when her water broke? So hopefully she knows this, and we're going to talk a little bit about those moms that don't have any or very much prenatal care. So I need to ask mom, is there just one in there, or do we have more than one? When are you due? When is your due date? And then kind of take it from there. Just a little bit about when you get this call. For those of you who are running just a single ambulance service, you may need to think about calling the next closest town to your scene for extra help, depending upon what you're dealing with. And I would say make that call sooner rather than later, so we don't end up being behind the 8 ball. You can always turn them around if we've got time. You can always turn them around and take mom in on your own. But if we get into a situation where we need more people, calling sooner rather than later is going to be a very big deal, especially if we get to the scene and mom says she's having twins. Now we're going to have 2 more patients on the scene, and we're going to need a whole nother team. So definitely think about that. Just like I said, if we get those twins or multiple newborns, we need to make that preparations. We need to prepare extra equipment. How many of you guys have 2 OB kits in your ambulances? You know, it just doesn't happen. Usually that OB kit is that thing that's covered in dust way in that bottom shelf that we never ever hope we have to use. But it should be, we should have probably more than one just in case we need it. It's going to take 1 responder to resuscitate that first baby while the second provider delivers the second baby. So we're going to need more people. Consider calling for that second ambulance. Consider getting more help there. So we've got our, on a key concept side of things, we have a premature delivery. That's going to be defined as less than 36 weeks gestation. So on the ALS side of things, we need to prepare our airway equipment to come into play there if we're going to have a smaller baby, if we're going to have a premature baby. So knowing that due date is going to be really important when we ask mom that question, and then kind of doing the math from there and seeing where we're at with things. Make sure that we have those appropriate sized pieces of equipment that we may need to use to start the resuscitation effort if it's needed. Another key concept that we're going to talk about is that greenish color meconium. We have a meconium stain baby where that infant has passed a fetal stool. If we have time, we may suction that baby's mouth and then the nose as it's coming through the birth canal. Some of these, or the majority of these, I guess, are going to be under some of that. They're going to indicate some of that intrauterine stress, especially hypoxia. So these infants are going to be short on oxygen. So one thing that we don't necessarily want to do is overly suction these, overly aggressive suction these infants, because it could cause that infant to vagal down, and we could lead to bradycardia and lower that heart rate. And we want these infants' heart rate to get going. We want things to get started and get rolling. We don't want to end up taking them the other way. So now we got our case progression again. Patient states she has only 1 baby, so she is near term, and the color of the amniotic fluid is clear. So what equipment do we need to deliver? We need to get our OB kit out. We need to get our sterile gloves out. We need to get all the equipment that we have in our OB kit out and get ready to go. We also need to make sure that we have plenty of clean linens around, so we can take care of mom, and we can get mom on some clean sheets, so we don't expose that infant to anything that could cause an infection, and expose mom to anything that could cause an infection. So prepare that area, keep that room warm, even if it means cranking up the heat a little bit more to where we might be hot. We're going to be sweating anyways. I've been involved in a couple of these situations, and they make you sweat for sure. So even if it's to a point where it's maybe a little bit warm for us, it's going to help the baby quite a bit more. So we're going to talk a little bit about the 2 delivery positions that are more the common ones. We have the supine position, and then we also have the Sims position. And I guess I'm probably a little more familiar with the supine position, which probably most of you are as well. Lying on their back on one side of the bed, place a stack of folded towels to raise the buttocks up. Suctioning the baby's mouth and nose before delivery of the body is difficult when we have the mother in this position because most of these infants are born face down. So the Sims position, I think I'm going to kind of refer to Linda a little bit on the Sims position. If you want to talk about that a little bit, Linda.
Okay, the Sims position, a lot of times that was very much of a midwife delivery. With the Sims position, you're going to find that you have less pressure on the perineum. So say if you end up with a larger baby, you're going to have a less risk of tearing. Also too, for myself, it's a little bit more controlled. Also too, being on the side, you're going to be able to suction because you're going to be able to see the baby's face in that. And it's what you'll do, you'll hold the leg up and you'll be able to just gently let mom push when she feels the urge to push, and you're going to be able to guide a little bit more. And neither position is wrong. You have to look at the situation. There are times that you just don't have time. So, and a lot of times out in the field and that, you're not going to have time. It's just whatever position she is, that's what you're going to deliver. It's just kind of more of your experiences in that is how you're going to deliver. It just being in the Sims, you're just going to have a little less risk of tearing because you're not going to have that quick push on the perineal area and the rectum and that.
All right, thanks a lot. And I was talking with Linda this afternoon about this, and I think she mentioned it in there too, is you have a little bit more control in the Sims position where you don't have that explosive type delivery where, you're pretty much just catching in the supine position. And one thing to also remember in the supine position is we don't necessarily need mom on the edge of the bed. We kind of want a little bit of room there so we don't have to catch the infant, and there's not so much pressure on us as responders at the end of that bed. So if we can give ourselves a little bit of room on the end of if it's a bed or if it's a couch or wherever, it's only going to help us and probably make it a little bit easier on us. So like Linda said, we can do some suctioning in that Sims position prior to delivering the rest of the body of that infant. So supine, just like we talked about, positioned over the side of a bed. Best positioning for suctioning the baby at the perineum. But again, that they're face down is going to be more difficult. Disadvantage is we need to catch it. And Linda talked about some of the advantages of the Sims position. All right, so now we are into this. We have the baby's head is out. Allow that mother to push the head out. Guide the baby out. Don't pull the baby out. Let the mom do the work. Most babies are going to deliver themselves without assistance. Although we might have to control that delivery a bit, only minimal interference with that natural process is going to be necessary. Next, with one of our fingers, we're going to feel the infant's neck for the umbilical cord. So we need to make sure that umbilical cord is not wrapped around there. If we can, if it is wrapped around there, we're going to go ahead and try to get that over the head. If we can't get it over the head, we're going to try to take some of that pressure off the baby's neck as that cord is being delivered. Place a hand around that neck posteriorly to control that delivery. And then as needed and on occasion, that infant's anterior shoulder may need to be kind of pulled out a little bit. And how we're going to do that is by placing a hand on either side of the infant's head and gently pulling downwards to try to get that shoulder to come through the birth canal. It might get kind of caught up on that pubic bone of mom is what we could see there. So that we're delivering the baby, keep the baby at the level of the vaginal opening, tie the cord in two places and cut it. There is some different things with this now, where we can possibly wait a little while before we cut the cord. There are some different thoughts out there, and as I was going through this the last few days, the 2020 neonatal resuscitation guidelines are telling us that we can go ahead and put baby on mom to get that warmth and to get that bonding going, and to also have mom start to breastfeed baby to start those uterine contractions to control some of the bleeding and the hemorrhaging that could potentially happen. So they're telling us that we have some time, that we don't have to do that clamp right away. We need to get baby onto mom, get mom breastfeeding that baby to start those uterine contractions. But if that is only when we have a delivery that everything's going good, baby's looking good, everything's working. If we have any issues where baby's going to need some care, then we're going to go ahead, clamp, cut, and start those resuscitation efforts on the baby. Linda, do you have anything to add on that?
I think that you've done very well covering it. One thing too, there has been times that as a head's coming out, you know, and oh my gosh, you're feeling the cord, and say you may have a nuchal cord ×2. Okay, in other words, the cord is wrapped around the neck twice. You may not be able to slip it off. Now, Kyle, do they, in their OB packet, do they have force-up clamps where they can clamp the cord and cut between?
Yep.
Sometimes that does happen. There is a vast majority of babies that are born with nuchal cords. For the most part, we can get those cords slipped off over the baby's head. But occasionally, babies will be born with what we call a tight nuchal cord, and we can't get them slipped off. And they're tight enough, you're not going to be able to deliver with the ability to slip off. If that happens, just remind mom to blow and put one clamp on each side of the cord and cut between to be able to just get that cord unwrapped around baby. One thing too, always make sure you do the shoulder next to mom's pubic bone first, because if you deliver the lower shoulder that's next to her rectum, you are more than likely going to have a pretty significant perineal tear. You know, so always use the shoulder closest to her pubic bone to deliver first.
Great, thank you. All right. So we get baby out, we're suctioning baby's mouth and nose, and then begin that resuscitation of the baby as needed. And going through some of these 2020 NERP guidelines is we do not need to suction aggressively, and sometimes we don't need to suction very much at all if everything is going good with baby. Now, if we get to the point where we are having some issues where baby's limp, lifeless, then we're going to need to suction a little bit more aggressively, but not too aggressive to where we put that baby into bradycardia. So I'm getting just slightly ahead of myself here. So we'll back up just a little bit. Delivery of that placenta is non-emergent. So we're just going to kind of let that happen if we have to start working on baby. So now our case progression, our baby's born limp and lifeless. No respiratory effort is noted. He is blue. What do you do now? It's too late to say that you quit. We are in this thing. We are going. We are rolling. Well, now we need to start acting. So what we're going to do next is we're going to dry that baby off. We're going to warm them up, position them, suction them, and stimulate that infant. We need to clear that airway. We need to assess those breathing efforts. Where are we at? If that baby is breathing, but our heart rate is less than 100, we need to go to vague mask ventilation. If and we're going to do that for about 30 seconds. So in most cases, it's very important to emphasize that need to dry them off quickly, to stimulate them and get that nose clear. If that baby remains apneic, now we need to proceed into the airway management. So some of our key concepts here is oxygen. We need that oxygen. That baby needs that oxygen. Some evidence out there suggests that hyperoxia can be harmful to a newly born. Do not give the supplemental oxygen to the vigorous newly born. If we have a vigorous newborn, they are of good color, they are looking like they're healthy, we don't need to give that supplemental oxygen to them. We will give oxygen to our compromised newly born or a newly born who have the low oxygen saturation. If we have that bluish color, that's where we're going to give our oxygen. And then also with that group, we're going to go ahead and assist ventilations as needed. So now our infant is going to remain apneic after those initial steps. What do we do next? We are going to extend the head slightly on the neck. We're going to position our hands at the EC clamp, and we're going to ventilate at 40 to 60 breaths per minute. We don't want to push too hard on the soft tissues. Avoid pressing down too hard with the mask onto the baby's face. That again can go ahead and cause bradycardia. It could trigger the trigeminal reflex. We need to instead lift that baby's jaw up into the mask with our EC clamp. 40 to 60, and the best way to do this is say squeeze, release, and continue on like that. So that helps us maintain that appropriate rate and allows that adequate expiratory time. So now we're going to assess the heart rate. In our newly born, a low heart rate is usually due to hypoxia, not necessarily cardiac related. This infant is hypoxic. The crying active baby usually is going to have an adequate heart rate. Assess that heart rate carefully. And an infant who is not active and who does require that assisted ventilation. It's going to be most easily accomplished by palpating a pulse at the base of the umbilical cord. If the cord pulse cannot be palpated, we're going to go ahead and listen for the heartbeat with a stethoscope then. Count the number of beats over 6 seconds and then multiply by 10. Sometimes the umbilical vessels are constricted, so the pulse is not palpable. And again, if we can't hear that or feel that pulse, we're going to go ahead and listen over the left side of the chest using our stethoscope. So now we're managing this infant. We have our heart rate remains below 60 beats per minute after 30 seconds of our vague mask ventilations. Now we're going to go right into chest compressions. 3-to-1 ratio, pause to deliver our breath. 90 compressions in 30 breaths per minute is where we want to be. 120 events per minute is what we want to see. So we're going to do our chest compressions right in the same place that we do them in our infants. You guys all learn, and most of you probably teach CPR. The nipple line right below it is where we're going to do our compressions. Now you might think, well, I just taught a class of CPR and they were talking about 30-to-1 and 15-to-1. One thing that I'll talk about before we continue on is if any of you have done a neonatal resuscitation class, you'll realize that there's quite a few different things with NERP. And I strongly encourage all of you, BLS providers as well, to get into a NERP class, a neonatal resuscitation class, and understand what some of those differences are. Because we don't always just get called to the 2-year-old that we can consider, or the 1-year-old that we can consider an infant, or the under 1. We might get into that neonatal call where that's from 0 to 28 days is where they consider a patient to be neonate. So we could be called to those types of patients, and we kind of need to know what some of the differences are going to be. I know I took a NERP class a couple of years after I became an EMT, just kind of on a whim. I think I actually needed some hours and got into a NERP class, and I learned so much. And that's kind of why I don't maybe run away from teaching this stuff, is because I did learn a lot early on as an EMT that really set the stage for feeling somewhat comfortable in these situations. I mean, you never feel like, yeah, bring it type of a situation, but if you have that training and you understand those things to do with our neonates, it's going to make you a lot more confident when you're in those situations. So our compression rate, 120 compressions per minute, 3-to-1 ratio, just like we talked about, 30 breaths, 90 compressions, 120 events throughout that minute. So now for our advanced life support folks, if that heart rate is less than 60 beats per minute after another 30 seconds of CPR, then we can consider intubation, depending upon what your standing protocols are. We also can prepare epi. Dose of epi, 0.01 to 0.03 micrograms per kilogram, or 0.1 to 0.3 milliliters per kilogram. Of the 1 to 10,000, either endotracheal, IV, or IO. The preferred route for epi administration in a newly born is via the IV route, and then down the ET tube or IO. If our vascular access is not available, then we can go the ET route or the IO route. So now, carrying on with our symptoms that we have with our infant that we've just been talking about. We have poor perfusion, we have weak pulses, we have that poor response to resuscitation. A shock at birth is going to be most commonly due to that severe hypoxia and acidosis. Blood loss during delivery caused by umbilical cord avulsion or fetal placental transfusion is an uncommon cause of shock in the newborn. Sometimes we think that if we don't get that cord cut, we're going to have that fetal placental transfusion, and it's going to cause that baby to go into shock, but it's relatively uncommon. Signs and symptoms of shock are going to be, they're lethargic, abnormal color, and tachycardic, and then that prolonged capillary refill time. Sometimes hypothermia can also mimic a patient that's in shock, a newly born that's in shock. So on the ALS side of things, assure that we have that adequate oxygenation and ventilation. Because the hypoxia is the most common cause of depression in newly born, our initial resuscitative efforts should make sure that we have that adequate oxygenation and adequate ventilation. Fluid resuscitation should be limited to 10 milliliters per kilogram of normal saline to avoid putting our patient into potentially congestive heart failure. And again, these ALS protocols are going to be based on your protocols as well. Everybody seems to have a few different things based on what they do and what they're trained to do. So make sure you are up to speed on your ALS protocols. So BLS is usually all that's going to be required for our field deliveries. And it makes up the largest area at the top of this pyramid. So we look at always needed and we look at infrequently needed. So always needed, we need to dry them off, we need to warm them up, we need to position them, we need to suction them, and we need to stimulate them. And as we go down that kind of inverted triangle, is towards the bottom are the things that are very infrequently needed. Most of the time, BLS is all that we're going to do in these types of situations. So our case progressions. we have, after our vague mask ventilation, for 30 seconds, the heart rate increases to 140 beats per minute. The baby becomes pink centrally with cyanosis only of the hands and feet. Our baby begins to cry. We then go ahead and discontinue our vague mask ventilations. We wrap that baby up in a dry blanket and we get that baby to mom. Now we're focusing on our second patient. So it's going to be up to you and what your service protocol is on how you're going to transport your infant. I'm not going to tell you which way you need to do it. But I will say that it's probably a little bit better to have mom holding baby and have that baby on mom's skin, allowing the mother to breastfeed, because that's going to go ahead and contract that uterus and take that potential for hemorrhage of mom and lower it. Linda was telling me a case earlier where that was the only thing that probably saved mom from going into shock and potentially dying, was she started breastfeeding, and that started that uterus contraction and allowed things to kind of level out a little bit. So our biggest thing is keep that baby warm. Even in the hot days that we've had here recently, we need to go ahead and crank that heat up in the back of that ambulance. We need to make sure that's a nice warm area. That baby's just coming out of mom at 98.6 degrees and nice and warm in there, and we bring them out into the world. And even if it's a couple of degrees cooler, we could send baby down that path that we don't want to send them by getting them too cold. So get that back of the ambulance nice and warm. And I mean, we're going to be sweating more than likely, but that's okay. Keeping our baby warm, we may need to potentially secure them to the backboard. If they are still compromised, provide our airway management, make sure we're still keeping them warm, maybe get a blood glucose value as well, and we're going to go ahead and transport. Sometimes the depressed newly born or a premature delivered baby is at a risk for hypoglycemia. But this complication is going to be unlikely to develop in the first 30 minutes of life. If our transport time is longer than 30 minutes, then we can go ahead and get a bedside glucose approximately 30 minutes after birth. And if we are under 40, then we're going to need to look at treating that, or at least getting a hold of our medical control and letting them know what we have. So our case progression, things are starting to look up here a little bit. After delivery of the baby, we have no maternal hemorrhage. We prepare to transport the baby in mom's arms. We restrain mom on the gurney. We still have to be safe. We still have to make sure that we don't have anything happen to our now 2 patients. We need to make sure that they are restrained on the cot to the point that nothing can happen to them if we have to brake suddenly or we hit a bump or whatever. So we get to the hospital, we're directed to the postpartum unit where the mother and baby are admitted. They are discharged the next day. Life is good. We all know that that's not what happens sometimes. And we'll get into a couple of those questions that you guys asked here shortly. So our case summary, although most of our field deliveries are going to be normal, the rate of complications is higher for an out-of-hospital birth, just because we maybe don't have that controlled environment. We don't have a team standing by that does this thing every single day. So positioning, suctioning, and drying are going to be those only interventions that are usually needed. Once we have, or if we get into the situation where we have a depressed newborn, we're going to go ahead and use that graded approach to management. We're going to do our steps like we talked about, making sure that we know what the next step is. We always need to be preparing for that next step and base everything that we do on that baby's heart rate and their respiratory efforts. And one of the things that we also have to think about is if we have a depressed newborn, is don't forget about mom. because we could be so focused in on our infant that we're working on that mom could take a turn for the worse that we don't realize. And now we're dealing with an exasperation of 2 emergencies. And we have limited personnel, more than likely. So make sure that we are always taking care of mom as well. So, any questions before we talk about a couple of other things that were brought up? Does anybody have any questions, any comments? I hope you guys enjoyed it. It's one of those topics that it seems like we always need it as EMTs, but sometimes it's hard to get somebody to do one of these classes. And we were just lucky enough to have Linda jump on board to kind of answer some of our questions. So one of the questions before we get into that, does anybody have anything from the crowd? You can go ahead and put them in the chat box, or you can go ahead and ask them if you have any.
One of the comments I might make is that when you are suctioning your babies, we have a tendency to get a little excited. Make sure that when you're suctioning, you are not doing a deep throat suctioning, that you suction more on each side of the cheek. One of the things that if you do a lot of deep suctioning down the throat, you can get that baby into a vagal response and it will drop their heart rate. So when you're suctioning, be gentle and just kind of go more into the cheek side of each of the baby versus deep down into the throat. Because in the earlier days, in that I've seen it where we have caused our own our babies to have vagal responses, and then their heart rate drops, and then you've put yourself in kind of a catch-22.
So here's one, Linda, that just came in. If IV access is warranted, do you suggest umbilical cord or IO?
I tell you what, unless you have an experience of how to do an umbilical cord, you know, if you've got the experience, you have to follow your protocols. You know, everybody has, you know, like you said, Kyle, everybody has their own protocol. If they don't have the experience, but you can go ahead and do an IO. Our physicians have said IOs will work. Starting an IV on a newborn that is in shock is very, very challenging, and you're wasting a lot of time trying to get something started. So follow your protocols and go with what you are taught.
Very good. Did that help, Joey? Awesome. Anybody else? Any questions before we go into some of the pre-questions that we've got?
One of the other things I might make a suggestion too is that if your baby is doing good, everything's great, stick that baby on mom's chest, skin to skin. That mother is the best incubator that you can have. In the hospital, after baby's born, that's one of the first things that we do is put baby skin to skin. Mom's body temperature will regulate itself to keep baby warm, and then have a nice heated blanket over mom. And that will really keep baby nice and warm in that. Obviously, if you've got a baby that you're having to resuscitate, then it's a different story.
Linda, one we got earlier, and I'm sure you've seen this multiple times, is what about those moms that come in with little or no prenatal care?
Oh.
How would we react to that in the field? Would it primarily be just the information that we can get from mom on how far along she thinks she is, stuff like that? Do you have suggestions there?
That's basically what you're going to have to do is, you know, ask her when her last period was. Has she even seen a doctor at all? One of the notes that I wrote, and especially now, is a lot of the drug concerns.
Mm-hmm.
You know, and I don't know, are you guys able to use Narcan at all?
Yes. Yeah, all the way
Okay.
to the BLS level. Yep.
Because, you know, that's one of the things to look at, you know, and then again, what was she using? Because some drugs you do not want to use the Narcan with because it'll not be good for the baby. It'll make it more shocky and that. So, you know, that's one of the things. What was there any drug usage, alcohol usage, prenatal? Have you seen the doctor at all? Sometimes it's a guess and by gosh, no, we haven't. Well, then you have to start looking at mom's belly. You know, does it look like she's even pregnant at all? You know, that's probably the scariest situation for anybody involved, whether it's on the field or in the hospital. The unfortunate thing is that on the field, you don't have a lot of chance to say, hey, wait until you get to the hospital, you know, and you just basically have everything laid out and just, you know, have hope for the best.
Hmm.
You know, one thing, if it's a preemie, chances are very seldom with premature births do we see a lot of meconium. Our meconium is more with our term, close to term births. Only if the baby is just in really, really severe distress in utero will we see actual meconium on a preemie. You know, it's more of those term babies that we see that meconium.
Okay.
And again, be careful with suctioning because you don't want to vagal on you.
Awesome. One of the other questions that we got was from an individual who is 20 minutes to close to an hour from their nearest hospital, from their nearest ambulance.
Oh,
you know,
wow.
What should they have as first responders? And one of the things that I think is just potentially having an OB kit in your jump bag, if that's what you need. Is go ahead and do that. Here's a question. Would we handle a group B plus mama any different than not?
I tell you what, normally what we would do in the hospital, we would start antibiotics post-delivery. What would happen, being on the field in that, you wouldn't handle things any differently. You would go ahead and deliver, but you would make sure that as soon as you get into the hospital, that the nurses, the doctors, and that are noted that this was a group B strep positive mom, because what we would do, we would need to then be reactive on that baby. Drawing lab works, you know, it depends how baby's reacting as to whether we would need to start antibiotics post-delivery on that baby. You know, what we do is in the hospital, and we hope for the best that we can go ahead and get a couple doses of IV antibiotics on board before mom delivers. You know, preferably we like to use ampicillin unless she's allergic, but sometimes moms deliver fast enough, they may only get one dose. And then we just observe baby, but we'll draw lab work to make sure that baby's doing okay. And normally, instead of letting that baby go home right away post-delivery, then we're going to have baby stay longer to make sure that baby is doing okay. But the best thing you can do is just do a nice delivery on that baby, you know, and we can take care of that baby post-delivery.
Very good. Chuck Bell, did you have something? You're muted. I don't know if you want to be unmuted or not.
Think.
Okay, you were unmuted. I didn't get any of that. Or now you're muted. Did you have a question or a comment?
Can you hear me now?
Yep, gotcha.
Okay, well, now it shows me muted. Okay, here we go. Linda, thank you, because point being is, the first thing you need to do is, as first responders, is take a deep breath, because we got to take care of this little baby and mom. We got 2 patients. I got to figure out what I was going to say here. Okay, I wrote some stuff down here. Number 2 is, if you're running a ground truck on a BLS truck, get ALS going now, and I mean yesterday. Number 3 is your ALS aircraft is going to be Fargo or Sioux Falls. Get them in the air yesterday. Reference, I'm working up in Mobridge. There's no such thing as pre-hospital, or excuse me. I got to report. I'm stuttering. There's no such thing as prenatal care. 98% of the babies up there have got meconium, and be ready for that, be ready for that, be ready for that. You got to train on that. Number 2 is reference OB kits, carry 2 kits. Number 2 is carry 2 hats. Linda, I don't think you talked about that, but I'm gonna step on your toes. You need to carry 2 hats to keep those babies warm, and carry some extra OB blankets, okay? And reference ALS. IOs are so much faster, okay? I'm done barking, okay, Kyle?
All right, thanks a lot. Appreciate it. Anybody else? Any questions? Any comments on the chat at all? Well, before we let you guys go tonight, we're going to talk a little bit about the next 2 months. August, which is going to be August 26th, is our next webinar. And we are going to do concussions. It's a great time to do those, since we're leading right into football season, where we're going to be having standbys at football games. So we're gonna talk concussions in a few weeks, 4 weeks, I guess, in a month. It's going pretty fast. And in September, I'm gonna just kind of turn it over to Michaela and let her tell you guys what we're working on for September.
Thank you. So September, we are working on doing a pediatric panel. So we'll have a couple doctors, a couple EMTs, advanced EMTs, as well as physician assistants, and just some key players that are kind of throughout the state. Talk a little bit about pediatric emergency care, and we'll have a panel discussion. If you have any suggested topics or anything that you would like to see at that panel, feel free to shoot me an email, Kyle an email, or on that registration, which all the registrations are up till the end of the year. You can drop it in that box as well too, and we'll make sure that they're covered, because it's one of those that we really want to stress the pediatric emergency care.
Yeah, awesome. Looking forward to that. Sounds like it's going to be really good. So again, a big, huge thanks to Linda. We're working her to her last day, pretty much. She came through huge for us on this. And in my mind, nobody better to talk OB than somebody who's been doing it for a lot of years and who has the reputation of being a great OB nurse for her patients. So a big, huge thanks to Linda. Wish her very well in retirement. We're going to miss her around this office. I know that for sure. And there's also going to be an evaluation coming up. So go ahead and fill that out before you leave for the evening. Michaela, do you have anything else?
Nope. But like I said earlier, I guess all the registrations for the webinars are up till the end of the year. So you can go on to nesdahec.org/EMS and you can register till the end of the year.
Awesome. Some people having some issues on the CEU side of things. I'm going to put my email in this box. If you have not registered on the South Dakota EMS portal for your continuing education hours, and you're a BLS provider, go ahead and send me an email. I'll also reference who was on the call based on who is signed up and make sure everybody gets credit. Also, if you're ALS, again, I will be sending you your certificates for this one as soon as I get them. The Board of Osteopathic Providers sometimes a little slow at getting back to us, but they usually come through for us. So once I get those, I will email those out to all of our ALS providers. Without anything further, Linda, do you have anything else tonight?
Nope.
Again, a huge thanks
Look,
to Linda. We really
Let's hope
appreciate
you guys don't get caught with the baby on the route, but it's going to happen to everyone.
We'll keep you on speed dial. All right, make sure you're answering those evals as they're coming out. Make sure we get that in there. Yeah, I don't think I have anything else. Sandy, do you have anything? I guess not. Well, Michaela, are we good?
Yes, we are. So thank you everyone for attending, and be
Right.
be sure to share this about these webinars with your fellow EMS providers at your service.
Yes, fill these rooms up. We're continuing to grow this and hoping to keep it going for a long time. So have a good day, everybody. Stay safe. Take care.